So if we can reorganize up here for just a second, we'll do the panel discussion. And so we'll have all, Dr. Hopkin, Dr. Kallish is going to cover all the genetics questions, and Dr. Hopkin will be, he's in another session now. And then you'll see Dr. Hopkin and Dr. Wallace later this afternoon if you still have other questions.
I have two questions. The first question is a little general, but and this may be for the geneticist. In regards to the research that we have, so we had mentioned that, or it had been mentioned, that the development of the GLP-3 was started at a very young age. And my question is, if the parent has Fabry and is on enzyme replacement therapy or one of the therapies, is there any evidence that this affects that development? Does the medication cross the placenta? If so, is that a positive thing to do for a fetus? Is there any evidence on this or any data?
Is this on? Oh, good. It's a really good question. We don't have any data there. Certainly we know because of the inheritance that when Fabry disease is passed on, if the pregnant person, if the female parent has Fabry disease, who is the one who could potentially be treated with enzyme replacement therapy during a pregnancy, even if there is some impact or reduction of storage material in her during her pregnancy, we don't have any good data about whether or not that has impact on developing fetus or developing child.
Okay.
I think as Dr. Hopkins showed, we know that it's really limited data, small numbers of biopsies and studies that are done during pregnancy or in utero, that there is storage from very early on, or if we have biopsies from very small babies, we know that there is some data, but some storage early on, but we don't have data yet on whether or not enzyme replacement therapy during pregnancy has an impact on that.
My second question was in regards to the prevalence of anxiety and depression in people with Fabry disease, and specifically pediatrics. I know there's been mention that it's more common for us to have those symptoms. Is it more common than the general population? Is it because of the Fabry? I know it's difficult to say, is it the chicken or the egg, but is it because of the Fabry disease, like the dysautonomia, or is it something because of the symptoms? And if so, or regardless, how do we advocate for our children in the school system? Because you don't want to sit there and tell the teachers, hey, be on the watch out for changes in my child because of this. But I also, at the same time, you do kind of want your children to be screened, since those would be the people seeing them the most.
They're really good questions. We don't have data to suggest that there's a direct link between storage of GB3 and some specific cell type, and that's what's leading to the increased rates of anxiety and depression. But we know that anxiety and depression are common in the population overall, but certainly are more common in people with many different chronic illnesses. So we know that just the idea that you have an illness, that for children, as they start to understand that this can have impact on how they feel or on their health in general. If children have parents, aunts and uncles, grandparents who are having complications, they see a lot more than we maybe give them credit for. Needing to have treatment, and for children who are treated, that means IV therapy, anything that makes children feel different, look different. Even IVs in and of themselves can be really anxiety inducing for young children. So having and living with chronic illness certainly has an impact on all of us, and especially on children. I think it's a really good idea to talk to the children's school. Obviously you you let them know that they have a condition, it might impact them missing class and things like that, but also letting them know that we are on the out for anxiety and depression. Also discussing it with their pediatrician, who they're probably seeing more frequently than they're seeing their geneticist, their pediatric neurologist, their other specialists. So that if that does occur, then early treatment, whether that's through psychotherapy, which we know can be really helpful for children, sometimes with children with play therapy, if your children are seen in a children's hospital setting, if you have access to a pediatric hospital, often there are a lot of really good resources for age-appropriate psychotherapy and counseling, and sometimes even medications are helpful for children.
I will add that
We have another comment over here, Jerry, before you go on.
just in the public school system, you can the parents typically have to request in writing an evaluation, and in it can mention the Fabry disease diagnosis association with anxiety, depression, and executive dysfunction, and request a formal evaluation. It may not qualify for services through school, but typically that can't be done by a doctor, even though a doctor's letter can be helpful alongside with it. The school has to respond appropriately, and typically that involves a school psychological evaluation, even if it's just accommodations. That's one step forward. If anxiety or depression significantly impacts their ability to their behavior, then a functional behavioral analysis can be requested to be able to, when problem behaviors arise, that the school can manage it rather than automatically calling parents in a state of crisis. That can also be done for potentially pain crises, so that schools have a plan about what to happen. And then yes, child life therapists can be very helpful in infusion clinics to help make sure that that experience is less anxiety provoking, because certainly that can be another big source of anxiety compounding on others.
I also have two questions. The first one is for Dr. Mehta. You talked about the protein in the urine and everything, and you specifically mentioned albumin. But is that something we have to specifically ask for that, or is it already in the panel for the labs and everything like that?
That's a good question. It is not part of routine screening. So you have to specifically, your primary care physician, I'm sure, is aware of that test. It's a urine albumin creatinine ratio, and it's done on just a spot urine sample. There is no 24-hour urine collection needed. In the old days, we used to do 24-hour urine collection looking for albumin, but we don't do that anymore.
Okay, thank you. Ask him what? Would our nephrologist automatically do that? If we're
Yes, your nephrologist
They'll-
should definitely know that.
okay.
Or find a new nephrologist.
Okay, thank you. I have one more question.
If it's helpful, it's also part of guidelines for management for both pediatric and adult patients with Fabry disease. So if you're seeing a geneticist or a nephrologist or anyone who is specifically managing Fabry disease and looking at those published guidelines, that is part of those recommendations. So hopefully that's helpful.
Yes, thank you.
It is now part of recommendations for diabetes as well. So anybody who takes care of diabetes patients should know what this test is.
Okay, thank you. And then Dr. Abreu, you talked about, or on one of your slides, it had mentioned the mean weight for boys. What does that look like for girls? Because when we first started looking into all of this, we were told that men have a harder time gaining weight and women tend to be a little bit heavier. What does that look like for my teenage daughter?
Yeah, others can answer on the panel as well, because growth is not my specialty, but ultimately in the paper that I was referencing, it seemed that growth was normal in their study for females with Fabry. That being said, clinically we do see issues with growth and both yeah, ultimately, it's an issue that's under-recognized.
And I think that there are probably two parts to it. So when we talk about growth, in children, we think about height growing, and then we also think about healthy weights. Some of that is in chronic illness in general. We can sometimes see height, like the growth velocity, how tall you're growing, impacted. And we tend to see more severe disease in boys from that growth overall general impact, at least what our data shows now. In terms of weight in Fabry disease, most of the impact really, I think, comes from GI symptoms and malabsorption. So either if you're malabsorbing nutrients, then that can have impact on height and on weight. But if you're not feeling well when you eat, so if you have the early satiety where you feel full very quickly and you're not eating much, if you're having nausea, vomiting, abdominal pain, diarrhea with eating, then that would cause many people, especially children, to not eat as much and can impact weight. We don't have as much good data on overweight being specific to Fabry disease or having specific sex differences.
Thank you.
Yes, I have, like I previously mentioned, an 8-year-old, but I also have a soon to be 15-year-old. My oldest, he has a lot of the GI issues. If we go to dine out, usually, even before we leave the place, he already has to go to the bathroom. And I was used to that. But now, something that I have recently started to notice, vomiting. He would come home, and even though he went to the bathroom already at the dining place, he will go again to the bathroom at home, but that will be accompanied by throwing up. Not intentionally, it's just something that he can't contain, like it just happens. And that is something that didn't used to happen to him ever, and I'm noticing it now. Is there something that you guys can tell me about that?
It's quite well described, nausea, vomiting, especially after a large meal. The only recommendation, other than medications, which I don't want to get into, would be smaller meals. Smaller, more frequent meals are better tolerated many times. Some of my patients swear by the type of the food that they eat that trigger these diarrheas and nausea, vomiting. And on the other hand, I also have patients who maintain meticulous food diaries are unable to find a trigger. So I'm not sure diet doesn't work for everybody, but there are some patients who believe that fatty foods trigger that post-meal vomiting.
And usually he doesn't even get to, like, he's the one that I struggle, that I'll be like, you order that and you're not eating. Like, he would eat, but he doesn't eat the whole thing. So it's not even that he's getting this huge amount of food.
Is he seeing a pediatric gastroenterologist?
No.
So that might be, we try to limit, not have everybody see every doctor, because who has time for that if you can help it? But I think when you're having GI symptoms that are not being managed well by either the pediatrician or the geneticist, then it might be a good idea for him to see a specialist to find out exactly what's going on and to figure out how to best treat him.
And also another thing that is currently happening with him often is that the pancreases, where we live, we are from Ocala, Florida. The campus in high school is very big, meaning oftentimes he has to rush from one side of the campus to the opposite side to make it to his next class. Depending on the time of the year, it triggers the pain crisis for him. He would have to go to the clinic, and oftentimes I ended up even picking him up, because then he stays and he tries to go back to the classroom, and he ended up going back and forth so many times, and at the end he just gives up and stays in the clinic because the pain just doesn't let him focus and get through the classes. Initially, when we were living in Pennsylvania, they talk about gabapentin, but when we moved to Florida, we stopped that because we didn't dive into it. We were just getting the information and all of that. And then it wasn't mentioned in Florida like he needed that, or if it was something that we should look more into it. So we never really did. Is that something that I should look forward for him or not?
Yes. Yeah, ultimately, any child that's not able to access their school, that's something that needs to be addressed by their medical team. And there are daily preventative pain medications, of which gabapentin is one, but there are many others worth exploring. And certainly, there's ways to manage triggers, so modifying his classroom commute, allowing longer times. If he's in a public school system, having those kinds of accommodations could potentially be written into a 504 or IEP to be able to accommodate those needs, separate from the preventative pain plan and then the acute pain plan, what to do when those episodes happen.
Okay, thank you.
Talk about 504 plans this afternoon.
And then I have a question for, I think, Dr. Kallish, but maybe
We'll ask and we'll decide.
somebody else, I don't know.
Yeah.
Me personally, anxiety. It comes out of nowhere. It gets to a level that sometimes I feel like I can't function. I mentioned that I don't know if it's because I have Fabry myself and then managing the kids. But I have noticed that it's been increasing to a point that it inhibits me sometimes to being able to do just normal things. I work, my husband work, and I try to push myself to do, somewhat of a normal life, but oftentimes it's more that feeling of overwhelmness and just not being able to sleep, because for me the pain comes at night. I don't have any episodes during the day at all. I don't know why, but it's just at night. And I'm not resting well. I wake up in the morning and I'm already tired, and I'm already stressed about that, and it's just hard to focus and get everything done, even with all the help from him in the house. So it's just really hard.
Yeah, I mean, we know that these are really common problems for people who are living with Fabry disease and people who are living with chronic illness. And I know we spoke a little bit earlier that, because you've moved, you both were very busy getting your children set up and established and getting their care, and have also had some difficulty getting care for yourself. And we know in a condition like Fabry disease that impacts males and females differently, we've seen over and over again that female patients tend to get their children settled first and take care of themselves later. So, we know that I would imagine that it's been weighing on you, that not only that you're managing your children, that you worry about your children, that they're still struggling, but that you're not managing your own disease right now while you're doing that. So I think that, certainly I will speak with some people who I know, and we'll see if we can try to get you connected to some Fabry specific care. In the meantime, if you have a primary care doctor, that would be a good place to start to talk about the anxiety symptoms, because while anxiety is more common in people who have Fabry disease, it's not treated differently. And so trying to treat at least those symptoms while we work on the Fabry specific stuff might be helpful.
Okay, thank you.
Mm-hmm.
Keep in mind, mental health resources that we have available to help with people who are having some anxiety, stress. It's a free program. We have a hotline, we have some counseling, we have other resources. So we put things on, we have webinars, some of that.
If you didn't hear that, Jerry said, I was going to repeat, Jerry said that they have a lot of resources through the NFDF on their site, including some access to free counseling and webinars and things like that. So if you haven't looked there, that's a good place too, in case anyone didn't hear Jerry.
So this is a behavior question. I noticed a lot of the questionnaires asked if there's trouble concentrating and things like that. My little was diagnosed with ADHD, and I'm wondering if it could be more connected to the Fabry and less ADHD.
Yeah, it's tough to know. Ultimately, cognition and mood, especially in children, is just not well studied in terms of how does Fabry impact these areas. Executive dysfunction clearly seems to be affected in both children and adults. Right now, our ways to diagnose behavioral disorders in children is what's used as the Diagnostic and Statistical Manual, 5th edition, DSM-5, of which there's a certain set of criteria, which ultimately oftentimes is either based upon certain symptom questionnaires or a clinical opinion, including both home and school, about problems with inattention or hyperactivity to make an ADHD diagnosis. Whether or not it's Fabry-specific ADHD or ADHD and Fabry, two separate and unrelated things, ultimately is not known. But we do see an increased prevalence, and you're totally smart to make sure that an adequate diagnosis is made and that treatment, both with behavioral therapy and or medications, depending on the situation, is started so that they can function like any other kid.
Would the medication be any different based on which, if it was the Fabry or the ADHD, would she be affected on how it reacts in her body, I guess?
Typically not. It's just because of there's some additional cardiac monitoring needed for stimulants, and so ultimately the pediatrician, in working with the Fabry team, should just make sure that any medication is cleared by either the pediatrician or a pediatric cardiologist if they're on your team.
Thank you.
Nara?
First of all, thank you all for being here and sharing your knowledge with us. That's very important to all of us. I have a question about the vagus nerve, if you see it commonly affected by Fabry disease, because I did the tilt bed test, and they are the same day I had to put the loop recorder, and they are considering that I'm having issues in my vagus nerve.
I can take that. I can tell you from the cardiac viewpoint, people who have dysautonomia have features that are consistent with hypervagotonia, which means that the vagus nerve is activated, and so you have a fall in blood pressure, and you have the slow heart rate that Jerry talked about earlier. A vast majority of what happens in Fabry occurs in the brain and the central nervous system, as well as the peripheral nerve endings. And so I'm not aware, maybe Dr. Abreu is more aware, as to whether or not specifically the vagus nerve is more affected in the central nerve trunk as opposed to the peripheral nerve endings. Regardless, however, as we talked earlier, people with Fabry have more dysautonomia, which manifests as not just problems with heart rate and blood pressure control, but problems with other autonomic nervous system features, such as the GI motility, we've talked about that, with the sweat glands. And so all of those are part and parcel of what happens with the vagus nerve and with the sympathetic nerve endings. So it's true that vagus nerve dysfunction and or peripheral nerve dysfunction is more common in Fabry people, but we treat it the same way. I think somebody had asked me earlier about using drugs such as fludrocortisone, which is a hormone that allows the body to retain more sodium and water when people have low blood pressure. And we also use other drugs to keep the blood pressure up, such as midodrine. So irrespective of which nerve is affected specifically, if the terminal manifestation of the nervous system dysfunction happens to be problems with heart rate and blood pressure, then we use the same drugs we use in people without Fabry to treat those conditions. But we do have tests, specific tests to determine what the problem is. So we have tilt table tests and what's called QSART, which are sweat tests, and other kinds of tests we can do for the peripheral nerve function to determine where the problem lies and then direct treatment accordingly. I hope that answers your question.
It did. Thank you so much.
Kim, Liz?
Is this on? Okay. My family, which is now 18 people diagnosed, were just diagnosed 2 years ago. And our family variant is late onset, and we're able to take Galafold, and we're super happy. But my question is, will our children and grandchildren have late onset, or could they, down the line, somebody come up with classic?
So it's a good question. We know that the genetic change, the variant that determines whether it's classic or late onset, is the same in a family. So if you have Fabry disease and you pass whatever your mutation is onto whichever of your children inherit it, and so on, it's always the same genetic change within the family, which means if you have a clearly late onset variant, then we would expect all of your relatives to also have late onset disease. We know that there's variability, so you may see, especially in a big family like yours, there's some sex-related variability that we've talked about, but even within people of the same sex, there's variability. So that doesn't mean all of the males in your family will have the exact same disease course or the exact same symptoms or the exact same lack of symptoms, but we wouldn't expect anyone to have the severe classic disease if it's a known late onset variant.
Thank you.
It's also important to keep in mind that we talk about them a lot like they're different, but they're really kind of like a rainbow, so there's a lot of middle ground too. But again, they would stay the same through the family.
Okay. Can
I want to emphasize the variability. The biggest reason is I have patients in the same family that have presented differently. And so the variability is quite dramatic in sometimes, even though the mutation is the same.
Okay, and we do have some variants. I have one more question. What's the ideal age to test children? We all have grandchildren. And when do you start treatment, even for children without symptoms?
So this is really hard. I think when we talk about classic disease, in my mind, diagnosis early is super important. Because if we saw, and Dr. Hopkins showed most of the data on children, we know that young children with classic disease can have many symptoms from early on. And when we know they're at risk, we're better at asking those questions and determining that they have symptoms. And in classic disease, we know the male patients are really at risk for developing kidney disease in childhood, having significant symptoms in childhood. And we often do treat children with early onset disease in childhood. Later onset disease is a lot harder. I think because we know that it can have impact, I would generally advocate for testing children earlier rather than later so that their parents know that they're at risk. Even though we know in some of the later onset variants, and I showed that data from that specific common cardiac variant, we rarely see symptoms in any of those patients. We rarely see kidney disease, so we really see cardiac disease beginning in the 20s in the male patients. I still recommend, we know that means some people will have disease from their teenage years, and so at least screening them for those features while they're children can help us identify the few who have earlier onset of that late onset disease. We have a lot of patients who defer treatment, either till adulthood, some who defer treatment until they see any signs of disease. And I think that we don't really know right now when is the right time to treat someone who is at risk for late onset disease that we don't know when it's going to occur.
Okay. Thank you so much.
I'm going to tie into that for just a second.
Oh.
Can I just kind of loop in there 1 second on hers with the grandchildren or the parents of the grandchildren? If the children were to start treatment, I think somebody was asking about this earlier, does that impact, like if a woman were to get pregnant, or what would, how is that going to impact them as going forward as being pregnant?
we certainly we certainly treat children now with classic disease and children with later onset disease when they're symptomatic. Treatment, every single specific therapy. Are you asking about treatment during pregnancy, or just in general?
Sorry, if we were to treat children, is that going to impact them later, their fertility or
Treating
whatever?
children does not impact their fertility.
Okay.
It does not change the likelihood of whether or not they pass on the condition. The one consideration in some currently available treatments, and that may be a consideration in the future with additional treatments, is when people are pregnant, sometimes there are some medications we recommend less in pregnancy. Certainly those are conversations that I have even now with my female patients who are around family planning ages in choosing when to start therapy and which therapy to start. But there's no differences. One important part is that we know that especially for heart disease, but also for kidney disease, we have concerns about people with chronic illness becoming pregnant. So our goal is certainly to keep people as healthy as possible if they'd like to carry pregnancies in the future.
Thank you.
I have to Kim's going to go next, but I have Alex, could you grab, okay, could you grab Hannah from outside and tell her I need her up front? Thank you.
Hi, I just had a question. I've had a punch biopsy. I know I have small fiber neuropathy, and it causes a lot of pain in my hands and feet, my legs. I'm fine with that, but it seems to really bother my gut, like a lot of GI issues. And I was wondering, I know there's no way to reverse the small fiber neuropathy, but is there a way to slow down the progression?
Not that I know of.
Okay.
That being said, a lot of the Fabry-specific therapies look at abdominal pain as well as pain in the extremities, and so it does seem to be that there seems to be some mitigating effect or some helpful effect of Fabry-specific therapies, whether it's enzyme or chaperone. The extent to which is hard to know. Ultimately, with GI, sometimes a motility specialist can be helpful, a GI specialist who focuses on the nerves going to the gut as well as how it moves. And so if your GI doctor is not the most helpful, sometimes it may be a subspecialty GI doctor that could be helpful.
Alex in the back.
Hey, good morning. First of all, thanks, doctors. I appreciate all of your information that you've provided. The running joke that I always have, when I explain to somebody that I have Fabry's is, I'm a millionaire. I should have been more specific because the bill that I see that goes to insurance, when I go through all these doctors, I'm like, wow, should have been more specific and asked for cash. In any case, this is more from an administrative perspective. I'm a nomad. I'm able to work remotely. I'm very blessed with that. So when I'm transferring, from one hospital to the other, and I'm dealing with physicians who are not aware of Fabry's, is there like a one-stop shop for you all to say, hey, this is what to expect for your multidisciplinary team? Because I see a lot of me educating them about the background, and it gets a lot sometimes when I'm dealing with that. So I'm wondering, where's a good place for them to see that? And then also, if there's as a new patient, it's very overwhelming too when you're hearing a lot from different providers. Is there a patient-facing place that someone can receive the information too? So, yeah.
It's a good question, and I know, we talked a little bit about putting a team, everyone talked a little bit about putting teams together and recommendations. I mean, as a geneticist, I think geneticists are really helpful in dealing with rare disease because that's all that we do. So unfortunately, here you're lucky to have nephrologists and cardiologists. I think neurologists do more rare disease than other specialists, but to have specialists who see a lot of Fabry disease and so are experienced, but in many centers, your nephrologist, your cardiologist, you might be the only patient they're seeing, or at least they may believe you're the only patient they're seeing because they're not thinking about Fabry disease.
Right.
So geneticists, if you have access to one, this is what we do, is rare disease, so we are very comfortable going to resources, going to the medical literature, dealing with things. I see lots of patients with Fabry disease, but there's many things where I only see one person with that condition. This is what we do. So I think that's a good starting point if you have access to a geneticist. If not, there are some resources in the medical literature. There are guidelines that are published about how to monitor and when to treat patients. There's like a genetic site called Gene Reviews that reviews everything on a number of diseases, and there's one for Fabry disease. So those are good places to send your doctors.
Sure.
Also, our industry partners are really, really helpful. So if you've been on a treatment, your case managers can help with, other people within our industry partners who specifically are clinician facing and can go and will offer to do education to your physicians to help with that.
Awesome. Thank you.
I would add to that, frequently what happens is one physician out of the team will take the lead physician role for Fabry, and then they will build the team around it. I had to do that for Dallas because at Baylor in Dallas, we didn't really have a team. And so I had to identify a Fabry cardiologist. I actually found somebody in fellowship to try to get them involved and then let that grow over time. So sometimes you have to find one lead person it could be a geneticist, it could be the cardiologist, it could be a nephrologist, somebody who's interested in the disease and is willing to put in the time to educate others.
Yeah, awesome. Sounds like a good opportunity for some of our pharmaceutical companies to also help out with leading that effort.
And I'll just add that our industry partners often know in many, many places who is prescribing and who is seeing patients. So if you are on therapy, then whoever you're connected with, if you're going to I'm moving to wherever, they may know where you should start. And if you're not on therapy and you're looking for someone, then I'm sure that any of the companies that are working in this space are also willing to work and help patients who are not getting therapy. So they know who's across the country.
Thank you. And I lost my mind for a minute, so that was Newt asking the question, not Alex. And Alex is passing the microphone around. So we have time for one more quick question, Joe, and then we'll reserve all the rest of the questions until the afternoon session.
Thank you. First of all, thank you. Appreciate everyone being here. So I do have a cardiac variant, classic Fabry, and one of the fun things I found out is I also have a thoracic aortic aneurysm without rupture. Yes. That's a more recent discovery. And so I guess really my question is pretty simple. One, I think it was Dr. Mehta talking about all classic males should be on, a stroke prophylactics such as Plavix. That hit me in the brain pan. And number two, Dr. Kalra, when it comes to having a complication that looks to be separate from Fabry, could you maybe just speak for a second about common treatments or hey kid, you should be aware of this.
I would start and then let Dr. Kalra add afterwards. Whether a classic male should be on prophylaxis with aspirin or Plavix or not, I'm fairly certain that everybody should be on it. But your particular scenario, when you have a higher bleeding risk or rupture risk, that's a conversation between your Fabry specialist and your cardiologist saying, what is the size of the aneurysm? What is the rate of change of the size of the aneurysm over the last 3-5 years? What is the risk of rupture? That kind of discussion.
Yeah, so let me address your question about the thoracic aortic aneurysm first. We know that people with Fabry have a slightly higher chance of having dilatation or enlargement of the aorta. Typically, it happens in the first few centimeters of the aorta, so what's called the sinus of Valsalva, ascending aorta. The thoracic aorta actually loops around. It starts here and then goes all the way down here. So it goes up, then it comes down, and all of that is the thoracic aorta. So you'll have to find out where in your thoracic aorta the enlargement is, because the size, normal size varies. The aorta gets smaller and smaller as it goes further along the body. So the risk of rupture or complications is very much related to what the size of the aorta is. So for example, in the ascending aorta in a man, a normal size would be about 3.7 centimeters. So if it's 3.75, that's small. We monitor it, we look at it with MRIs or CTs, and if it's stable, i.e. it's growing less than 1 millimeter every year, we're less concerned. We will still put people on treatment. That treatment would be blood pressure control, as Dr. Mehta earlier emphasized, because blood pressure makes the aorta grow, higher blood pressures make the aorta enlarge. So it's a good idea, even without having hypertension for a lot of folks, to be on medications like angiotensin receptor blockers and beta blockers because they prevent aortic dilatation. The second thing I would do is actually see a vascular specialist or a cardiologist who's really familiar with this, because sometimes there's a separate gene that is causing thoracic aortic dilatation. So, people can be unfortunate times 2 rather than just 1. I mean, we know that Fabry leads to this, but you don't want to miss a second syndromic cause of thoracic aortic dilatation. And then third thing we emphasize is, for people who are weightlifters or like to pump iron a lot, don't lift.
Is it that obvious?
Just trying to be euphemistic here. So you don't want to lift more than 50 or 100 pounds at a time. Aerobic exercise is good. So there's a lot we can do in terms of monitoring. So I would definitely see a specialist who knows what they're doing in this area.
I can just add, if you are seeing a geneticist as part of your Fabry care, they may be able to help with the genetic testing. I actually, in my non-lysosomal life, do a lot of genetics of aortopathy or aortic disease. I'll say that unless your aorta is very big, growing rapidly, or you have a strong family history of aortic enlargement outside of Fabry disease, it's less common for us to find a second cause. But if you meet those criteria, absolutely agree it's worth looking, because it also could have implications for your family members.
Yeah, that I was very pleased to see my kids do not have. So,
but we know that that is something that can occur over time.
Sure.
So that's another good point, is that people who have Fabry disease get echocardiogram to look at their heart, which includes looking at that part of the aorta. Family members who have aortic enlargement in the family should also be having echocardiogram. So even if your children or your siblings or your parents, if they're here, don't have Fabry disease, they should be monitored with echocardiogram for thoracic aortic aneurysm. And then the third thing that I'll say about that is that and I have a pretty big population of patients with Fabry disease. We do see aortic enlargement in a significant number. I have not seen anyone who's progressed to needing surgery or dissection. So this is not in the literature at this point, but my suspicion is that it's less likely to be the kind of aggressive disease we see in other patients.
I agree with that. It's a more benign form of aortic dilatation, and also to add to the comment about getting echocardiograms only see the first few centimeters of the aorta. So if somebody who has not had a full screening of the aorta, we recommend an MRI of the entire aorta.
I'll send you mine.
And then the very last thing that I'll say, because I know that I'm going to be leaving after lunch, and I think probably we all are. I'm going to just volunteer for everyone. We're going to be at lunch, so if you had questions that you didn't get to ask now, come find us at lunch. We're happy to chat.
This was incredibly valuable. Thank you so much.
Great. So thank you so much to our distinguished physicians for providing the opportunity for you to ask questions. We will come back to this afternoon if any of you have remaining medical questions. So thank you all very much.